minutes, just to give you a heads up. Rest of you guys?
I can hear you, Dad.
All right, guys. So let me go over the exam, the 4 questions. I think you should have gotten most of them from it. So the first question was, which of the following receptors is responsible for the therapeutic actions of most cholinergic agonists? And the correct answer would have been C, which is the muscarinic receptors. So remember, we spent a lot of time talking about that this morning with regard to most therapeutic actions are based upon the muscarinic receptor. The second question was most therapeutic actions of cholinergic antagonists involve, and we haven't talked about this, but yeah, Kiara, I'll have Aiden and them to post everything this by Monday or so. Okay. So the second question was most therapeutic actions of cholinergic antagonists include or involve. We didn't talk about this one directly. We're going to start talking about those today, but we did address them a little bit when we talked about organic phosphate anticholinesterase drugs and doing that. But basically, the answer is A, which is competitive binding to the receptor. Most receptor interactions that we're going to deal with majority of drugs, there is very few drugs that interact with receptors in which there is a irreversible binding involved. Those are more the exception. So the point becomes is most interactions with receptors are a reversible, and this is with competitive binding, which means that other drugs that have higher affinities, whether it's an antagonist or an agonist, can displace them. And if it's a drug with a lower affinity, then you may have a larger dose. So a drug with a high affinity can be displaced by a larger quantity of a lower affinity drug. Okay. 3, the question was acetylcholinesterase inhibitors stimulate which receptors? Okay. Now, the way the question's worded, it's not the best because the acetylcholinesterase inhibitors actually don't, they're indirect binders, but they will elevate acetylcholine, which means that with the answers that you've got, the correct answer would be all of the above, because acetylcholine will bind to or stimulate muscarinic, nicotinic M, and nicotinic G receptors. Okay. And then the final question, which is something we will talk about a little bit more today, so it's a little ahead of it, is blockade of muscarinic receptors with blank heart rate. So blockade of muscarinic receptors, again, you should be able to possibly have reasoned this through, that if you block them, we know that stimulating muscarinic receptors slow down heart rate. We talked about the effects of the cholinergic agonist. So if you block the muscarinic receptors, that keeps the acetylcholine from interacting, and therefore it would increase heart rate. One of the actions we'll talk about with the drugs we're going to talk about here. Okay, so Aiden, if you will get with Marissa, and or at the end of the day, we'll have 2 sets of questions, and if you could post the answers maybe either Sunday night or Monday, just post the you can post the key or whatever that the way I've got it. Either one would be great. Okay.
I can Dr. post the whole.
Joni, Garland, the question is blockade of muscarinic receptors with blank heart rate, and the correct answer would be if you block muscarinic receptors, that will increase heart rate. If you stimulate receptors, so the correct answer was A. But if you stimulate receptors, that slows heart rate. So if you block it, it increases it. Okay. All right. So today we're going to move to, this afternoon, we're going to start off with cholinergic antagonists. What we'll probably get covered this afternoon will be cholinergic antagonists. We will also probably get the neuromuscular and possibly the antihistamines, or at least get into the antihistamine drugs. So to begin with, cholinergic antagonists, being an antagonist, we refer to those as often as blockers. So And again, the reaction that we see is going to be competitive. They're not going to bind irreversibly. The two drugs that we're going to use as our prototypes is atropine and scopolamine, and these are very similar. What we find is the scopolamine will tend to have a greater central nervous system effects because it penetrates further, and so atropine tends to be more peripheral, but we can still get some effects there. All right. So what we do see, and this is not unusual for a lot of drugs, is that there are certain tissues that seem to be a little bit more sensitive, which means that with atropine, that at very, very low doses, we will get the effects on the salivary glands, and it takes a real high dose to get, or it takes much higher dose to get effects on the GI and urinary tract in most people. So typically what this means is, for example, the first effects that most people will feel with atropine are going to be that their mouth dries up. Another thing that happens is their sweat glands will sort of dry up. And then we see the effects on the eye, which would be dilation, and the effects on the heart, which would be an increase in heart rate. And then the GI and urinary tract effects are the least resistant, or the most resistant, so it takes more atropine to get those effects. With scopolamine, what we find is that it tends to produce, the eye seems to be a particular sensitive organ, and we see it penetrates into the central nervous system, so we see more CNS actions than we do with atropine. So let's start with the effects on the cardiovascular system. When we give high doses of atropine, high therapeutic dosages, there's usually, I'm not asking you guys to know dosages on these drugs, but typically with atropine, we're going to give somewhere between 0.5 to 1 milligram for this. And what we find is that we will see that most of the time atropine at a moderate to high therapeutic dose will produce a tachycardia, and this is due to blockade of the muscarinic receptors. So let's just put that note here. This effect here is due to muscarinic blockade. Primarily, the vagus nerve innervates the heart. So as a result of that, it's normally releasing a small amount of acetylcholine, so that when we block it, the acetylcholine is released, but they can't interact with the receptors, or it's inhibited from doing that. And so therefore, there is an increase in heart rate. Sometimes at very small doses in a few patients, we actually see a decrease in heart rate. Atropine can sometimes stimulate the vagus nerve centrally. So that we see that it's not a real big deal, but the explanation seems to be a central action there. One of the things that's nice about atropine is it really doesn't have any direct effects on blood pressure. Most of its effects are going to be on the heart, and any effect on blood pressure may be due to the change in heart rate. We do see an interesting situation where that if a person gets a large dose of atropine, they may develop a flushing effect, and we refer to that as the atropine flush. They get real red. And there is let me see if I can remember that. There is a statement that they used to say all the time, and let's see if I can find that real quick. There was this thing that the medical schools used to always tell the students a long time ago, and let's see, what was that statement? When they would describe a person that had an overdose with atropine, They referred to them as, let's see, where is it? They would sometimes refer to the individual being mad as a hatter, um, dry. This all came from, by the way, atropine is very similar to a drug called belladonna, which is a natural alkaloid. And women used to use belladonna quite a bit back in the old days. Actually, belladonna refers to or means beautiful woman. And they used eye drops of belladonna to make their eyes dilate. And that was supposedly cosmetically appealing. And so they referred to the dilated pupils as being bedroom eyes. And that was one of the things that occurred. But we saw that there are several types of derivatives of this, but atropine being one. And that is, I can't find that little, it is something like mad as a hatter, hot as a hare, red as a beet, and dry as a bone, blind as a bat. That's the phrase that used to be used a lot. Just put it down here. They would describe someone who had been given a dose of atropine. So they described it as hot as a hare, such as a rabbit, and they would say red as a beet, which was dealing with the vasodilation or the flush. They would describe them also as dry as a bone because it dries up the secretions. And they would also describe it blind as a bat because of the dilation, which made it very difficult to see. And then mad as a hatter, which is dealing with some of the central effects. So that was a term that was used to sort of, in medical schools a long time ago, was described as toxicity to atropine. But atropine and these cholinergic agonists, really, we see belladonna, which was what was used. It comes from the nightshade plant, was what was sometimes used for this. So these are the effects that we see. On the GI and urinary tract, it takes a large dose to get an effect, but it would reduce motility and tone. You actually saw the motility and tone being affected more than secretion. So one of the things that they used to do was anybody that had excessive or bowel hyperactivity, they would try to give a cholinergic. Some people would use a cholinergic agonist. We have much better drugs now. But the thing is that theoretically this would decrease GI motility and would be antidiarrheal. The problem with it is that it took such high dosages that you also had all these other side effects that would occur. They also tried to use it for peptic ulcer. The idea that acetylcholine stimulates gastric secretion. And so if we could block that, the problem again was it took such high dosages that to get the blockade of decreased secretion in the GI tract is it basically created too many side effects, okay? It does favor urinary retention. What it does is it contracts the sphincter, so it sort of closes the outlet from the bladder. Again, takes high dosages. And so the problem when we used it, when it was first being used, the reality of it was effective, but the problem became the side effects were so bothersome. We didn't have other drugs, and so if we had to use it, sometimes compliance wasn't a good thing because of all the other side effects, which was excessive cholinergic blockade. So, again, we would use it and used it in the past primarily because that was the only thing we had. And so when we used it, we knew there were side effects. We knew a lot of patients wouldn't tolerate it or wouldn't take it. So they either wouldn't tolerate it because the side effects were so bad. So for example, if I had a heart patient and I had one with severe gastric ulcers, if I used the atropine to try to decrease secretion, decrease GI motility, one of the problems happened is I could elevate the heart rate. So that was a big issue. Its effects in the eye, as I mentioned earlier this morning, one of the things is that atropine, we used belladonna drops, we used atropine for dilating the eye so we could see the retina and, diagnose glaucoma. The problem was, I don't know if any of y'all had atropine. Most of you probably, if you've had your eyes dilated, it's been something with homatropine or another derivative. The problem with atropine is when we put the atropine eye drops in, it could produce a very prolonged mydriasis. Your pupils are really dilated for a long period of time, in fact, up to 2 weeks, which made it very difficult. They tried to dilute down to try to get less of an action, but we did see people that had psychoplegia, which means they couldn't see near and far distance and their pupils were dilated. So, when you leave the eye doctor after they dilated your pupil, they want you to wear the sunglasses. Of course, most people have a set of sunglasses they carry now, but they also give you those, really nice, sexy plastic ones, that you can put over. But one of the problems was the atropine was effective. It was just too effective. So when you put it in the eye, it took a long time for it to wear off. So even if it didn't go 2 weeks, it wasn't uncommon for someone to have their eyes dilated, and the eyes would stay dilated, a day or 2 days, but definitely for several hours. It's actually contraindicated in a patient with narrow angle glaucoma, because when the pupil dilates like that, it actually can increase the intraocular pressure and can damage the eye. So we use it, it can be used in wide angle glaucoma, but not narrow angle glaucoma. Just out of curiosity, does anybody know anybody that's actually had their eyes dilated with atropine? So I know when I was much younger, I had mine dilated, and so see now Jason just sort of threw y'all some shade there, Kiara, and because basically you're like me. If you're use the atropine, it was some time ago, and Jason comes in and goes, "Oh yeah, my grandfather used to have it done." So. Yeah, Shelby. The thing is that the eye doctors now do not use atropine. They use analogs of atropine. They act the same way. They're antimuscarinic drugs. The difference is the analogs are much shorter acting. So what we see now is what they use to dilate your eyes now typically wears off within just a few hours. So it's not near as long as what we used to see with the atropine. We do see that these drugs, both atropine and scopolamine, can get into the central nervous system. And so the high doses can produce excitation, hallucinations, delirium. Scopolamine, you guys are probably familiar with this. Some of you may have had this or know people that have had this. But the scopolamine patches that you put behind your ear for seasickness or motion sickness, scopolamine is used for that. Scopolamine is also used as a pre-anesthetic. Atropine is used more frequently as a pre-anesthetic, but scopolamine can be. Scopolamine can produce sedation, and it can also produce some amnesia. So, but the scopolamine, the biggest thing is, let's see if I included these slides here. Yeah, okay. So I want to give you a couple of things here on these cholinergic antagonists. So number one is, I'm going to give you two real life examples of this cholinergic agonist actions. So as I told you guys, with regard to, I had a legal case that actually went to trial, I think it was 2 weeks ago. And this was an interesting situation. So what happened is, this is dealing with atropine. So what happened here is there was a physician who is in Georgia here that runs a clinic, and it's one of these clinics. It's run in sort of it's a high-end area of Atlanta. That's where most of the patients come from. The doctor is pushing for, he tells people he uses non-FDA approved treatments, unconventional therapy, but it is used to lose weight, increase energy. So what this doctor typically does is he gives vitamin B12 shots He gives vitamin C shots, vitamin D shots, and then he gives things like choline and glutathione, and then he gives a shot of adenosine monophosphate. Okay, now the basis for this is that his theory, his rationale, if you will, is that the choline and the other amino acids is what your body uses for energy, and the adenosine monophosphate is involved in your body making energy. And so his idea is by giving these different things, basically it boosts your body's metabolism, it gives you more energy and burns fat. That is his theory, and that's what he does. So these women are coming in, and I don't know if he has men or not. I just know of the women that have come in. These women come in sometimes 2 to 3 times a week. One lady I know was coming in and getting B12 shots and was giving herself B12 2 to 4 injections per day, which he said was sort of excessive. So anyway, getting to how this relates here is that he was having a compounding pharmacy in another state that he would tell him, I want you to compound and send me the adenosine monophosphate solution so that I can inject it. And he would have them compound a couple of other things. So that's perfectly legit. There's no problem with that. A lot of physicians do that. Okay. So what happened was there was a mix-up. And so the compounding pharmacy sent, instead of AMP, adenosine monophosphate, they mixed up and sent atropine. Okay. Now, so the doctor gets the atropine, or gets the AMP, what he thinks is AMP. And then basically he gives an injection to, it turns out there were 4 women that received an injection from this vial that was misfilled. The women, all 4, had a similar reaction. Basically what happened was that they, within minutes of leaving the office, they started experiencing hallucinations, amnesia, confusion, delirium. All 4 pulled over. Either someone stopped to see if they were okay. They all went to the hospital. These were 4 separate, going to 4 separate hospitals, and so forth. So the women all experienced, we didn't know at the time that occurred, they did not know what had happened. They just had these women that were having these, these confusion, delirium, a little bit of psychosis and things like that. All of them experienced dryness of mouth. All of them experienced a little bit of tachycardia. So they were basically held for anywhere from 24 to, I think one lady was held for close to 72 hours. So basically they treated according to symptoms. Of course, we didn't know what had happened at that particular time. And so the hospital didn't know the atropine would not have shown up on a routine drug test. So when these women reported back to the doctor, he basically called the pharmacy. The pharmacy had him FedEx the vial back, and they sent it to a third party to analyze. And so basically what happened was these 4 ladies all experienced atropine intoxication. The pharmacy, I was actually in one sense on the side with the pharmacy, but on the defense, my testimony was pretty much what would an overdose of atropine do, and which was all 4 women demonstrated, signs of this: excitation, hallucinations, delirium, dryness of mouth, slight tachycardia. All of them recovered. My biggest thing was on one of the ladies. She was claiming that this interaction caused her to have diabetes 2 years later. So I was involved with just saying that doesn't happen. But this was, so for example, with the atropine, one of the things that you ran into was this was classical symptoms of a atropine overdose. Its duration would be what you expected. So some people argue we don't even know what the lethal dose of atropine was. The atropine that these ladies got, when they analyzed it, there was like 90. So a typical dose is maybe, depending on what you use, anywhere from a half a milligram to maybe 4 milligrams, maybe 6 milligrams in certain, I think in intoxication, if you're trying to use it as an antidote. So typically 6 milligrams is about the most that anybody would get. The lady, all four of these ladies got 1 mil. There was 92.5 milligrams of atropine per milliliter. So theoretically, they got 92.5 milligrams injected, but they didn't really get that exact amount because not 100% of that is going to be absorbed. But so anyway, this is a case where we did have this, and this occurred and was an issue that came into play here. But basically, the other thing that's come up is some drugs very similar to this, like hyoscine, and some of these have been in some of these children's teething drops, and we've had some children that have overdosed. We've had, I think there's been some reports in the literature that people have gotten 150 up to about 600 milligrams of atropine and still lived. And so one of the things we're always concerned about is if there's any underlying other thing that can cause that. The other thing that I saw with scopolamine, just another situation, is this was in, there is a Russian regimen for tobacco cessation where they inject scopolamine behind the ear. And we had a person in the Atlanta area. The physician was fine, Kiara. The physician had nothing from a standpoint because he basically was given a drug that was, he was doing what he was prescribed. Now, I don't agree with his methods. I think that pretty much his method, because what he was using it for, theoretically it should, but your body is not going to, if you get excessive of these minerals and vitamins and amino acids, your body usually just gets rid of them. Nothing happened to him. The pharmacy was actually the main people that were sued. They, as soon as they found out what occurred, they contacted all four ladies, offered to pay. They paid all medical expenses. And for three of the four ladies, there was some money that that they gave them for, that they paid them. So there was no court. The fourth lady did go to court. The company offered her something like $275,000, and she turned it down, went to court and asked for $2 million. And the court found out, the court awarded her $100,000. So she would have been smart. She was no longer injured. There was no injury that was there. She was claiming PTSD, but she had kept going back to the same physician, getting similar injections like 23 times. So, so bottom line is that I thought the drug company did everything that a prudent drug company could do. They made a mistake. They fessed up to it, said exactly, this is what happened. What can we do? They contacted them. So it's just one of those things that the other three women had no problem with it, and they just wanted to make sure it didn't occur again. And the company has had a good record. So, but going to court and trying to go for $2 million resulted in her losing $175,000, coupled with the fact that her lawyer took this on contingency. So she got she got $200,000, and the lawyer gets 40%. So she could have had $275,000, and she ended up getting less than that. So she lost $75,000 for what she was offered a month earlier. Had to go to trial, week of trial. Jurors could not understand why they were in it. So it was an interesting thing. So with the scopolamine, we had an interesting thing here where a smoking clinic was saying we have 100%, almost 100% success rate. And they were using this Russian regimen where they inject scopolamine and a couple of other things. So there was this one couple, I was interviewed on TV on this one. There was this couple that their neighbors said, okay, they suddenly started acting strange. They were big, they had a cat, and they were very attached to this cat, and they ran a gym, which I thought was a little ironic that you run a gym, but you smoker. So suddenly their neighbors noticed that they were trying to give the cat away to them, and they were selling their house, and they stockpiled their house with cases of green beans. Little bizarre behavior. Okay. Neighbors said they were acting a little strange. In addition, this was some examples. Well, it turns out that these people had gone to the smoking clinic. they were getting injections of scopolamine behind their ear, and what they were having was actually CNS toxicity of the scopolamine. They were having these delusions. What they were doing was planning on selling their house, moving to live under an underpass in Atlanta. They were stockpiling the green beans because they were going to carry those green beans and stack them up under the underpass. And that was what they were going to live off of while they were under this underpass. And they were giving their cat away because they knew the cat would not eat green beans. So what we discovered was basically this was signs of scopolamine toxicity. This smoking clinic, one of the things, their high success rate was based upon that if you were smoke-free for 30 days, that was considered that you had quit. Most smoking clinics, it's at least a year. So here was an example of where someone was basically having some scopolamine-induced CNS actions. So a couple of interesting stories that have come up with these two drugs here. And actually, the other thing is all four of those ladies that had the issues, you know, had to go to the hospital. Every one of them experienced periods of amnesia, and so was consistent with cholinergic toxicity. Now, when we look at these cholinergic antagonists, there's several uses that are based upon them. They're primarily blocking the muscarinic receptor. In ophthalmology, we see them used to dilate the pupil. Okay, atropine was used, scopolamine was used. We use other drugs now because the atropine and scopolamine had such long duration of action. So we didn't really need that. So the drugs that we use now still act the same way. They still are blocking muscarinic receptors, but their duration of action is much shorter. Okay. Then, as I said earlier, is sometimes people develop adhesions in their eye. And so one thing that they can do is they alternate. So what they'll do is they'll give a drop of a mydriatic, a drug that will dilate the pupil, such as atropine. So the pupil dilates, and then they give a dose of the miotic agent, such as a cholinergic agonist, which will cause the pupil to constrict. So by alternating the agonist and the antagonist, the pupil basically dilates and constricts and dilates and constricts, and that can be used to break some adhesions in the eyes without surgery. So that's one use. These cholinergic antagonists are frequently used prior to surgery. One of the things that they do is, this is a big one, is if you're going to have surgery and going to be sedated, go under general anesthesia, one of the things we want to do is we don't want you having a lot of secretions because that can interfere with you breathing. So atropine is the one that's used. So it sort of dries you up. And a lot of people will complain about just before they go to surgery, they give them atropine or a cholinergic antagonist, and they will start talking about their mouth getting really, really dry. And that's part of its actions. In some instances, if we have individuals that may be very susceptible to vagal bradycardia, in other words, their heart rate starts slowing down, atropine is good for this. Some people following a heart attack will go into excessive vagal tone and the heart slows down. So atropine can be used to block that vagal response. The vagus nerve is releasing acetylcholine, and basically you put atropine in there to block that effect. So it keeps the heart from slowing down due to excessive vagal activity. Many times, since these drugs can produce some amnesia and can have some CNS actions, we don't have to use as large a dose as the anesthetic. So that the lower dose of anesthetic makes it safer. Scopolamine in particular was used a lot for its sedative and amnesiatic effects, especially in childbirth. They still use it, not as much as they used to, but women that were that are undergoing natural delivery, a lot of times they would give them scopolamine, and for a long time they thought that the scopolamine does produce sedation, but for a long time they thought that the scopolamine may actually have some analgesic effects, because these women would say they don't remember any pain or anything else like that. Well, where they were interpreting that the person didn't have pain, what they later discovered is that the person actually did have pain, and but they just couldn't remember it. So sometimes this amnesic effect in surgery is good. People don't remember those type of things. Sometimes some of these neuromuscular blocking agents we're going to talk about a little bit later on today, they do have, even though they're designed to work primarily on the nicotinic receptor, they may have some effects on the muscarinic receptor. So these cholinergic antagonists can be used to offset that cholinergic component of that neuromuscular drug. So anytime we want to block either the effects of acetylcholine or the effects of a muscarinic agonist, these cholinergic antagonists can be used. So I've already mentioned about the cardiac use. Some people after a myocardial infarction, their heart goes really slow, and that's usually due to excessive vagal tone. So we can use it to do that. And then, as I said earlier today, is these drugs originally were used for treating peptic ulcer. The idea was by blocking the muscarinic receptor, that decreased secretion that comes from the vagus nerve. Also, the vagal tone could cause some, we could see some not vagal tone, but we could see some spasm and slow gastric emptying. And so that seemed to be mediated that these drugs could do it. We don't see this used for GI disease, hardly any at all. And the reason for it is side effects. Where you might see it is the other agents that we use. If there's a reason that someone couldn't use one of the other agents and we didn't have anything else, we might try this. But the problem is to get this effect requires a fairly large dose of atropine or scopolamine, which also means that the chance for side effects are going to be, are going to be pretty high. So that's one of the things that we try to avoid here. Now, motion sickness, scopolamine. Atropine, not very good for motion sickness. Scopolamine is what we use. And one thing to be aware of is that the scopolamine patch has to be on about 30 minutes before so you can't, like, for example, get on a boat, get on a plane, and start getting nauseous, and then put the patch on. It doesn't work. So you've got to put it on, and typically it's at least a half an hour. So it prevents you from getting nauseous. It doesn't reverse it once you get nauseous. So scopolamine is pretty much a very standard drug that we use. It's available in a patch. There's some other drugs we use now that if you get nauseous work pretty well. We'll talk about those. These are sort of the antiemetics and so forth. But we'll talk about those when we talk about the GI system. But motion sickness and scopolamine, we don't see atropine being used very much. These are acting on the receptors in the vomiting centers and in the vestibular apparatus. We'll talk about those in detail. Muscarinic intoxication. So, for example, somebody ate a bunch of muscarine, ate a bunch of mushrooms. We're going to use these anticholinergic drugs to offset that. Or another way you would have muscarinic intoxication, somebody took too much pilocarpine. Now, sometimes what we'll do is that if the symptoms, for example, with pilocarpine, using that as an example, if the symptoms are not too bad, then, we'll just sort of wait them out and won't give another drug. But if the symptoms are bad and we know it's due to pilocarpine or due to a muscarinic agonist, then we will give something like atropine or scopolamine. We used to use atropine in asthma because the idea was with asthma would constrict, and we knew it could be some hyperactivity to the cholinergic side. But we find that the atropine doesn't work as well, and we find that it's not used very often in asthma. We have a whole lot of other drugs which are much better. Again, when I say much better, what you're looking at is the side effect profile is better. They have used some of these to treat allergies, but we tend to be using more of the antihistamines and some of those other drugs from a standpoint, because a lot of the allergic responses, although with the cholinergic antagonists, the problem is like atropine and some of these others, they can dry up secretions, which can help. But there's a lot of other drugs that are better. Oh, and by the way, I'm glad you asked that question, Jeeb. A number of drugs that you're going to prescribe have anticholinergic actions. So there's antidepressants, antipsychotics that can have anticholinergic actions. So they are going to have similar effects. In fact, that's one of the things that we always worry about. Say, for example, the tricyclic antidepressants are known to have anticholinergic actions. So what do we have? We see people that may have some tachycardia. We see people that sort of get dried up, may have some urinary retention problems. Those are things that are associated. So that's going to be very similar. So those drugs can basically have some blockade on cholinergic receptors, and that's why you may have cholinergic antagonist or anticholinergic effects. Let's see something. All right. Let me finish these next two slides, and that'll finish up our anticholinergics, and then we'll take a break and move to another class of drugs. So we talked about atropine and scopolamine being our prototype drugs. There's a number of what we've seen with a lot of the other antimuscarinic drugs is basically, for example, they are, we call this like atropine substitutes, which means that they may be structurally similar to atropine, but by changing their chemical structure, what we may see is some changes in properties. And so one of the things, as I've mentioned several times, is we use the atropine and scopolamine will cause very nice dilation of the pupil. It's very nice and very long. So what we've done is we've used short-acting mydriatics. These are the ones that you typically will run into in the ophthalmologist office now, is these are going to be much shorter acting. Typically wear off within an hour or so. Things like homatropine, tropicamide, cyclopentolate, all of those have been used to basically dilate the pupil, but they don't produce that prolonged dilation that you would anticipate. We've seen there's been also some work to try to develop drugs that are working by blocking the muscarinic receptor and producing smooth muscle relaxants. So there were some studies that were done, some drugs that were tried to be developed, that the idea was that they would be more selective on the GI tract. In other words, that you wouldn't have all the other antimuscarinic effects, that most of the effects would be on the GI tract. What they tried to do is make the drugs less lipid soluble so they didn't penetrate and go into other tissues as much, and that they didn't cross the blood-brain barrier. But the problem is some of these ended up having ganglionic blockade, so they blocked nicotinic, and that was okay from a standpoint. It may actually be beneficial, but the problem was it created significant side effects. So the side effect profile wasn't good. So there are a few drugs out there that people have used in the past that have sort of either not being used or have they basically are used only when other drugs are not working. And we also see some drugs, these drugs fall into like drugs called methscopolamine, propanthyline, dicyclamine. These drugs, we probably saw more dicyclamine being used of these three. But one of the things that happened is, again, as we've gotten better drugs, and in fact, what we saw is what we'll talk about either later this afternoon or tomorrow morning, is what we've actually seen is some of the H2 antagonists, the antihistamines, are actually much better. So we do know that the vagal nerve can alter secretion and cause gastric secretion to increase. So the idea was the anticholinergic blockade would decrease gastric secretion. And it does work theoretically, but what we find is that these antihistamines basically work better, better side effect profile, and seem to be more efficacious. We'll talk about those. Actually, we'll talk about them this weekend. We're going to talk about them a little bit more when we talk about the GI drugs. What we do see is some of these drugs are used for, like dicyclamine has been used for urinary incontinence. We see several women that get put on something like dicyclamine when they're having some issues with urinary incontinence. So we do see those coming into play here. But again, the anticholinergics that we're using all are primarily blocking muscarinic receptors, and preferably with very little nicotinic blockade. Okay. So let's take our first afternoon break. It's a little earlier than what we normally take, but that's fine. We're at a good block. We're a good, let me make sure I'm at the right place. Yeah, we're going to change to a different class of drugs. So let's come back at 5 after the hour, and then we'll start talking about these drugs that act on the neuromuscular junction. Okay. So I'll see you guys at 5 after the hour. And Aiden, I don't know if you want to take roll either when we get back or whatever, do your poll, just as a reminder.
Okay, doctor.
Okay, guys, let's go ahead and get back into this. So let's move to the next group of drugs, still related to the cholinergic system, but this time we're moving a little bit different over to the neuromuscular end plate. So we're moving away from the main actions on the cholinergic or the parasympathetic system. We're moving more to the somatic nervous system. So let's start with these neuromuscular blocking agents. And the big thing with these is, since we look at, go back to one of those slides that I showed you earlier today that showed the neuromuscular, or the somatic nervous system. And you notice that one, we have the cholinergic synapse right there at the on the motor end plate, and acetylcholine gets released from them or from there, and then acetylcholine is going to then stimulate nicotinic M receptors. So the first thing that we're looking at here with these neuromuscular blocking drugs is basically what we're looking here is we're moving to the therapeutic action being on the nicotinic receptors, and in particular we're looking at the nicotinic M receptor. Okay, the nicotinic on the muscular on the muscle. So we have two types of agents. We have, and I've got a couple of little videos for you guys tonight to look at, very short, 2 to 3 minutes, I think, that talks about these neuromuscular blocking agents. So we have the two types here. We have one is called a non-depolarizing agent, and these basically are going to, the drug itself is going to compete with acetylcholine for the receptors. Okay, so basically the drug, a drug like, for example, Curare, will be binding to this nicotinic M receptor, and instead of acetylcholine, it will find that this will bind. And these are considered reversible. Okay, it's not an irreversible binding typically. So those are non-depolarizing, and that is most of the type of drugs that we use, which are non-depolarizing. The other drugs, which we have one example of that we see used clinically, which is called succinylcholine, is actually referred to as a depolarizing agent. So what this means is basically when it binds to the receptor, it causes depolarization of the receptor. So it initially stimulates the neuromuscular junction and then blocks it. So the non-depolarizing binds and blocks it. The depolarizing agents basically will bind, do an initial stimulation, and then block it. Change slides for me automatically there. So most of the non-depolarizing agents are going to be competitive blockers, as I've said before. Like I said this morning, is many of our drugs, most of the drugs we deal with will bind competitively, which means that what we're doing here is actually giving either a drug that has a higher affinity for the receptor, for the nicotinic M receptor, than acetylcholine, or we have one that we're giving a large dose, so there's more of the receptor molecules that are, so there's more receptor molecules than there are acetylcholine. So this includes tubocurare or Curare. We also have pancuronium. These are two of the most common ones that are used, but we also have atracurium, metacurine, galamine, vercuronium. And again, different clinicians, typically we're seeing surgeons use these. Different clinicians will have a preference, but these are the ones that are used. Now, the problem with these drugs really come into play is that we worry about these drugs because they can block the neuromuscular junction. But our biggest concern with these drugs is the fact is, think of the muscles that you use to breathe. You have your diaphragm and you have all the accessory muscles. So remember, those are skeletal muscles that when we breathe. So if we block those muscles, then one of the things that happens is those muscles, we can't breathe. So people can suffocate. And that's one of the reasons why I've got a statement here is sometimes we may have to, typically we're going to use them and we're going to be using some sort of mechanical respiration. But if someone was accidentally poisoned with them, basically that would be an issue. So we'd have to use mechanical respiration until we either reversed it or until there was we ran into a situation where that it wore off. Now think about this. We know about, if you go to the previous slide, at the very bottom, I've got a person there, and he's this is a South American Indian, and they use curare for their tips of their arrows. Okay, so the concept here is that they're hunting game. So let's say they're hunting a primate or a lizard or a monkey up in the tree. If they shot it with their arrow and wounded it, then it can escape. Whereas if they shoot it with the curare on it, it paralyzes it, so the monkey can't go very far, or the primate can't go very far, or the lizard, or whatever. So that was the concept of using curare when they hunted, was it paralyzed the animal so the animal couldn't run off into the woods and where they couldn't get it. Okay, so when we're getting back to these non-depolarizing agents, when we want to reverse them, a lot of times we use the reversible anticholinesterases. How would this reverse this? Or let me ask this. Let me answer Jason's question first, and then I'll ask my question. All right. No, the depolarizing agents, basically, they initially, when they bind to the receptor, they will stimulate it. And then while it stays on there, but it's not an irreversible block. But they do have a higher affinity than usually acetylcholine. But it's when they first bind it, we get a slight little initial stimulation. And then after that, once it fires, it doesn't relax and then fire again. So it's like that one thing. But again, they do have a higher affinity than acetylcholine typically. Okay, good question though. Okay, so if we wanted to reverse these, why couldn't we use atropine? Where does the atropine work? What receptor? Right. So atropine works on the muscarinic receptor. These agents here, whether they're non-depolarizing or depolarizing, either one, they're working on nicotinic M receptors. So the atropine or scopolamine are pretty specific for the muscarinic receptor. So that's why we can't use it. So what we need to reverse these agents is we need something that's going to act at the nicotinic M receptor. Why can't we use acetylcholine? Why can't we just give doses of acetylcholine? Okay, so it's too low affinity, so we need a lot of it. What's another reason? Anybody? That's the person that's good is basically Eddie. This other thing is good there too. So one of the things is that we can't just use acetylcholine because number one is it wears off too quickly. It's broken down. Probably could not even get it to the site for enough period of time because it'd be broken down too quickly. It affects muscarinic receptors. We don't want to be stimulating muscarinic receptors to do this. We need to block. We need to basically to bump off to bump off this drug. So acetylcholine breaks down too quickly, wears off too quickly, be hard to get it there. So what we use is reversible anticholinesterases. So it's an indirect way of using acetylcholine. So we give these indirect anticholinesterases. They're going to increase the acetylcholine, make the acetylcholine stay. The concentration of acetylcholine in the synapse is going to increase and stay increased. So that's how we get around it, is basically we use these anticholinesterases that are going to elevate the acetylcholine level, and that bumps the neuromuscular blocking agent off. Okay. Now, these depolarizing agents, of which we really have only one, which is succinylcholine, basically is very short acting. But what you do see is when you give it, many times what will happen is that you will get, right after giving it, you will have these muscular fasciculations. What is a fasciculation? It's twitching, okay? So the muscle twitches a little bit. And what we find is that you have the initial twitching, and then after that, you get blockade. We do see that this agent can sometimes produce both changes. It can either see due to bradycardia or tachycardia, and that might be because it depends on which nicotinic ganglionic receptor it blocks, because it can block, if it blocks nicotinic muscle, if it blocks nicotinic muscle NM receptors, it's going to also block NG receptors. And that's one of the problems with all of these depolarizing agents. Although they are really, we're targeting the nicotinic M receptor, they can also have nicotinic G receptor. So we could get the bradycardia if it was stimulating primarily the parasympathetic ganglia, and we can get the tachycardia if it was stimulating the sympathetic. But it can also what it can basically do is that when it binds, it stimulates it, but it also can block those. So depending on what actually happens, you can get a slight bradycardia or tachycardia. One of the biggest things that we do see is that when we normally use these neuromuscular blocking agents is we find that they are used primarily by orthopedic surgery, or sometimes with trauma when they're trying to set bones or trying to manipulate. If we have somebody that's had a lot of trauma, such as been in a very, very severe car accident, you don't want to use the succinylcholine, because what it can do is by depolarizing it, it can cause a loss of potassium from the tissue. So when you've had extensive trauma, you've got a lot of potassium loss due to the trauma. Then if you stimulate it, you get some more. So that can actually develop. What happens is the potassium leaves the tissues and gets into the blood. And so you develop actually hyperkalemia that can occur. And that hyperkalemia, when you elevate potassium levels due to this hyperkalemia, then basically that can cause you to go into arrhythmias. So we have to be very careful. One of the big things that we worry about with using this, and typically we're using this with a general anesthetic, but one of the groups of general anesthetics is inhalation anesthetics, when they give you gas and to put you to sleep, that succinylcholine can produce a malignant hyperthermia. So this is a big concern we have to really be careful about. So we monitor body temperature very carefully if we're using succinylcholine. So malignant hyperthermia, what happens is basically your body temperature just starts rising, and you run fevers. You can run a fever excess of 105 or greater. So that is one of the things that we worry about with using these drugs. Now, this one has been moved in. When I first started teaching pharmacology, we talked about botulinum toxicity mainly because of poor canning practices. In rural areas, in the South in particular, a lot of people do a lot of canning. And one of the things is that you can develop botulinism, because if you do not use the proper sterilization techniques and so forth, you can get botulinum toxin in these canned goods, which can result in people actually dying, from this. Now we talk about botulinum toxin mainly for aesthetic purposes, primarily Botox. Okay, so what botulinum toxin does is, we're seeing it's used for migraines. We're seeing it used for some muscle issues like ptosis. So what botulinum toxin does is it enters the cholinergic nerve endings, and it inhibits exocytosis, which is that process of releasing the transmitter. So what we use it for is migraines, as mentioned. It's been used for strabismus and blepharospasm, so different things where the eyelid is drooping or the eyelid is spasming or things like that. probably its biggest use. In fact, there's a lot of ads on TV lately that I've seen talking about Botox parties and that sort of thing. They've been really pushing Botox. So the idea is that it's used for smoothing wrinkles, and but when they use it, again, we're typically using this from a standpoint therapeutically, is it's being small injections are being given many times subcutaneously. Typically, around the eye or the forehead, is we do see that sometimes you will get some excessive tearing, or we have seen people that they get ptosis, which means basically the eyelid drops, or sort of drops down. So those are side effects that can occur. Those usually will wear off once the toxin has been broken down and metabolized. From a standpoint, if someone ingested it, for example, eating improperly canned goods that's developed, it can cause death. It can cause respiratory paralysis and death. And this basically gives us basically shows sort of how Botox works, or what happens here is that it's a little bit on the molecular side. This came from a JAMA article. So what you have here, look at panel B, is that you have the botulinum toxin actually gets in here and gets taken up into this vesicle, and then it attacks these different snare proteins and can interfere with it. So what happens is you don't get transmitter released, and that's so this is the synapse. The Botox gets taken up into the presynaptic membrane, gets into the vesicles, and basically what happens is that you don't get the fusion and the release of transmitter. One last group of drugs, which is rarely ever used. In fact, I meant to look up and see if they're even available. But we used to have drugs that blocked the ganglia. And the idea with the ganglia, what happens is that we use these initially. I remember when I was taking pharmacology many years ago, that one of the things that we saw was that people that were hypertensive and wasn't responding to a lot, we saw a couple of drugs used. One was hexamethonium. The other one was trimethophan. And these drugs were used in patients that were, their blood pressure was very high, and the other drugs didn't seem to work. And I don't think even hexamethonium is available anymore. And I was checking for trimethophan, and I don't think it's available anymore. But these drugs, the idea was by blocking the ganglia in the sympathetic nerves, that would so block the nicotinic G receptors. Basically, that would decrease the amount of norepinephrine that's released, and blood pressure would go down. The problem with these drugs, they're toxic. They were just too toxic. I mean, when I say toxic, there were so many side effects that occurred, because it was like, I think someone used an example of the shotgun versus the rifle approach. This was basically by trying to block the sympathetic nervous system completely. Well, all the other systems that are involved with the sympathetic nervous system, not only the ones that affected blood pressure, but everything else would be affected. All the ganglia in the cholinergic system would be affected. So the reality of it was that these drugs we used only when nothing else worked. So from that standpoint, that was these drugs just, we saw as new drugs came out, especially in the 90s and early 2000s, these drugs just kept losing popularity. And so we see them used in experimental situations now, but not really with humans. You ask about the stellate ganglion block. If I'm not mistaken, when they're doing specific ganglia, what they're going to do is those are usually done either by surgical, where they go in and cut the stellate ganglia, or where they go in and inject locally, either an anesthetic or something that would block that. We see another thing that they use for is people with hyperhidrosis hydrosis, where they have excessive sweating. There are people that will, particularly their hands and their feet. I've known 2-3 people that's that. I had a secretary whose her hands in particular is like when handling paper, she just had this excessive sweating of the palms of her hand, and she would actually, if she handed you a paper, it would be wet. I have another friend, who's actually a friend of my daughter's. It's that passed away, and we've got to know her and her husband, and she has it with her feet. In fact, I used to play tennis with her. She was my tennis partner on a few years ago, and one of the problems she had was that the soles of her feet would sweat so profusely that she was having to constantly replace shoes because the lining of the shoes would just get super saturated. So they do go in and sometimes snip that. So when they're doing these blockades, that's a localized blockade. I'm not sure exactly what they do with the stellate. With this hyperhidrosis, they basically go in and cut it. So that's an issue. But when they're using these type of things, that's a localized, whereas these drugs were used more from a standpoint of a systemic. So you actually took them as a pill and they affected everything. So sort of summarize with the cholinergics, and then we're going to move a little bit different here, is most of the cholinergic drugs, especially the agonist and the antagonist, those are focused on the interaction at the muscarinic receptor. Okay, side effects are usually predictable. They're dose related. Sometimes when somebody gets a side effect, we're able to lower the dose and that goes away. Sometimes by moving to another agent, which may have a slightly different affinity, we may that can be fixed. But typically, the side effects, which you should be able to predict, if I give you an agent and say what would be the side effects, or give you a list of side effects, you should be able to pick them out. So typically, it's an extension of the pharmacology, which means that they're either blocking or stimulating muscarinic receptors. So that would be too much stimulation of a muscarinic receptor or stimulation of a muscarinic receptor in an organ or tissue. So for example, if I'm using a cholinergic drug to cause dilation of my pupil, then I would expect dilation. But if I got dilation that lasted too long or excessive dilation, that's an extension of the pharmacology. Or that if I'm doing the eye drops and I got systemic absorption and my heart rate started increasing, that would be due to stimulation of muscarinic receptors in my heart. Excuse me. I'm talking about an antagonist. If I gave atropine and I got too much vasodilation or too much pupillary dilation, then that would be indicative of excessive anticholinergic muscarinic blockade. If it leaked out into my systemic circulation and I started getting an increase in heart rate, then that would mean that I'm getting side effects due to blockade of muscarinic receptors in other sites. Or the other thing would be is if these drugs have, for example, with the acetylcholinesterase inhibitors, if they started affecting the nicotinic receptor when I wanted primarily a muscarinic response. All right, now let's move to another group of drugs which really are not. I include them sort of here because they're acting on the muscle, but they're a little bit different because they're not really they're not really acting directly necessarily on the cholinergic system. They're not blocking typically nicotinic or muscarinic receptors, but they're acting elsewhere. And these are centrally acting skeletal muscle relaxants. Now, this is a group that you guys need to be aware of because we have a lot of patients that will have skeletal muscle injuries, and so these drugs are used. But these drugs are going to be acting more in the central nervous system rather than the peripheral nervous system. And typically, these drugs can have central acting effects. Excuse me. So one of the things is that we got to remember is that these drugs, I'm trying to fix my pen, so bear with me. These typically are going to act in the spine or at higher brain centers. Okay, so we've moved away from the neuromuscular junction. So many of these drugs can have anti-anxiety effects or sedative effects. And the fact is we do know that when people get muscle spasms, it can be very painful. And as they get these muscle spasms, the anxiety increases, which can increase the pain. So by decreasing the anxiety and even producing, like, for example, people wake up due to muscle spasms, have a hard time sleeping. So the sedative actions can help them sleep. So, but what you have to remember is that when you have drugs that have anti-anxiety or sedative or in general CNS depressant actions, you've got to be careful with the drugs that you're using that may have CNS depressant actions. Typically, these are given with due to some sort of musculoskeletal injury or musculoskeletal problem. So sprained, arthritis, myositis is where you have an inflammation of the muscle. Here's a good example of what can happen. So when people start getting tense, they develop headaches, they may develop backaches and leg aches. And what's happening is the muscle is, when people get tense, the muscle can contract. And when it contracts, especially around the muscle or around nerves that are coming from the spine, that contracting muscle, and some of you have experienced this, is basically it's like a hard ball or a hard mass that can then push down on the nerves. And what happens is by pushing down on the nerves, that causes inflammation of the nerves. It causes the nerves to hurt, so the person can experience paresthesias, so tingling. They can experience pain. I mean, just think about this. One of the common causes of sciatica, the sciatic nerve runs down your, from your lower back down to the back of your leg. We see one of the common causes of sciatica is basically men carrying a wallet in their back pocket that has a big, overstuffed wallet with a lot of cash. We see it in a lot of old farmers and older people that, tend to carry a lot of cash around. And they stick a big wallet back there and sit on it all day long. What's happening is that is like a muscle. It's pushing against the muscle, which is then pushing down on the nerve, which is then causing muscle, both inflammation of the muscle or inflammation of the nerve. When you sprain or, have musculoskeletal injury, the inflammation can cause swelling, which causes the muscle to push down on there. So what we typically are going to do, the idea is if we can relax the muscle, that takes the pressure off of the nerves underneath, and that seems to help. Now, many of these, one of the problems with these skeletal muscle relaxants, and it's not uncommon, for example, one of the most common things we see is someone goes and is working, like this morning before class, I bought some mulch from one of the football teams here. So they delivered 40 bags of mulch, which unfortunately they delivered it with nobody to really help unload it. So I carried 40 bags of mulch. Me and the couple of people that came, we carried it up the thing. So one of the things that's going to happen is that I'm anticipating tomorrow morning is I'm going to be sore from just walking up an elevated driveway and that sort of thing. Okay. So one of the things is my muscles have worked. My muscles, when we work, sometimes the muscles will have micro tears in them that can cause inflammation. And so when people use this, one of the biggest problems we used to have is some of these skeletal muscle relaxers knocked people on their rear end. I mean, they were just sedated so much. We do know that a lot of them produce drowsiness, lethargy, ataxia, and sometimes some allergic manifestations, which are slightly different. But when somebody hurts their back, and let's say they go to the doctor will typically give them a muscle relaxer, sometimes an opiate, or some sort of pain reliever, even if it's something like tramadol. So here you have a opiate that's got a CNS depressant. A lot of times they'll give them a benzodiazepine. Sometimes they give them the benzodiazepine for its muscle relaxing properties, but that takes higher dosages. But a lot of times when this is used with an orthopedic injury, you're going to have a couple of other drugs that can be CNS depressants. So we have to be careful. And we saw some of these drugs in some individuals that pretty much when they took it, they were wiped out. I mean, they couldn't go to work, they couldn't drive, they couldn't do anything. So if some of your patients are on these skeletal muscle relaxants, be aware that this can be, can produce drowsiness, lethargy, or ataxia. We want to be very careful when we see older patients on these. May make them prone to fall, but especially if you're prescribing a benzodiazepine or other drug, an antidepressant or antipsychotic that may have some CNS depression actions, you want to be aware of that because that could be additive. So we have a number of drugs. We're not going to look at all of these, but some centrally acting skeletal muscle ones. Mefenacin, chlorphenicin, chlorzoxazone, cyclobenzaprine, carbamol, carisbrodol, metaxalone. So I'm just going to hit some of the common ones that are here. We'll start off with cyclobenzaprine, which is Flexeril. Again, I'm not requiring you to know trade names, but sometimes I'll throw the trade name out because sometimes you'll be familiar with it. This is one that's used quite frequently, typically prescribed short-term. A lot of times someone pull their back, pull a muscle, sprain, Flexeril will be given. The thing you have to be aware of is that Flexeril structurally looks very similar to a tricyclic antidepressant, okay? So, which if its structure is similar, one of the things you got to be careful about is if they're on a tricyclic antidepressant, then because the structure is similar, it might be similar to, you may have some similar actions, and so you may have a potential for toxicity. Just like with a tricyclic antidepressant, we don't want to use this in a patient on a monoamine oxidase inhibitor. The combination can produce some serious consequences. Numerous side effects with this, but most common thing we're going to see is going to be the sedation. And so with all of these, one of the big things is going to be the sedation. All right, so let's move to another one. Baclofen. So this sometimes is now I'm reading, trying to look at these. Most of the time it's just called Baclofen, but we have Vitarine and Lioresal. This one is going to act, it's going to be similar to GABA. It actually mimics GABA and acts on the GABA B receptor, okay? So it's going to affect different pain pathways, both mono and polysynaptic pathways. And this one we see used a lot of time when you have spasticity that may be associated with where either there is a lesion or some sort of damage to the spinal cord. We see this one used a lot for multiple sclerosis. Just like with Flexeril, we're going to see drowsiness, dizziness, can see confusion, weakness, some GI effects. If somebody's been on this for a while, we need to taper them off. Because if you do a abrupt withdrawal with regard to this, basically they can go into seizures and hallucinations. So Baclofen, we see, well, again, we see this for more serious injuries. A lot of times we're going to see Flexeril. Probably Flexeril is the one I see the most for most common injuries that we see around here. Another drug, which is dantrolene, this actually is going to act on the skeletal muscle. It's really acting sort of distal to the neuromuscular junction, so it's not acting to block that. What dantrolene does is it's actually acting on the calcium availability. So what it's going to do is it reduces the calcium in the cytoplasm. Remember that the cytoplasmic calcium is used to, the calcium from the cytoplasm is moved down to form the actin myosin filaments. So the idea here is by interfering with intracellular calcium, it's going to decrease the ability for the muscle to contract. See this used for, again, more serious interactions, spinal cord injuries, cerebral palsy, multiple sclerosis. This one is important because when people develop malignant hypertension or hyperthermia, one of the big things that we see is we see a lot of these individuals, what will happen is that the muscles will contract, and when the muscles contract, that generates heat. So what happens is dantrolene will relax the muscles, and that reduces the heat. So we use dantrolene frequently when we have indications with malignant hyperthermia. We do have some drugs you will prescribe. Some of the antipsychotics can produce malignant hyperthermia, so we have to be aware of that. And we may use dantrolene to treat it. Dantrolene, as you can imagine, if you're interfering with the calcium, side effects can be weakness. A lot of times people are drowsy. It's a sedative type effect. They may have some dizziness. The biggest thing we find, the most serious side effects, are potential seizures. We can see some inflammation of the heart. The pericardium is the sac. So we can see some pericarditis. We can see some skin reactions. And liver function needs to be monitored with this one because it can cause potentially liver damage. So a lot of problems with this. So we don't use it except in very, very serious situations. Okay. So that's going to sort of finish the cholinergic drugs. We're fixing to move in there. Let me mention one other drug is, in addition to Flexeril, another drug that we will see is a drug called Skilaxin. I'm just going to mention that with regard to this one. It's actually one that I mentioned earlier called, let me go back to it here. It actually is metaxalone. And so what happens with this one is metaxalone is, it's basically another CNS depressant. We call it a centrally acting muscle relaxant. And the biggest thing with it is, again, it can be any of these skeletal muscle relaxers. What we find is you've got to be careful because they do, every one of them will produce some degree of CNS depression. It can also produce ataxia. And so because of this, just be careful with these drugs when you are possibly one of your patients is on them, especially if they're older patients, because they may be more susceptible to falls. So when you're prescribing something that may be a CNS depressant, that is important. Now, the other thing that I will see, it's not uncommon for people to be on these drugs and be drinking. And so one of the things that we try to tell them is, if they have a couple of beers or, a glass of wine, when you're on one of these drugs, that can, it's not going to change your blood alcohol level, but it's going to significantly change how impaired you are. So one of the things that we tell them is anytime they're using CNS depressants, one of the big issues that we have to be aware of is that these muscle relaxants can produce greater CNS depression with other CNS depressants. So that's one of the big things that you're dealing with. Okay. All right. So I'm going to change slide sets. If you guys, we're going to go to the adrenergic drugs, and we may get through the adrenergics. I would be glad, hopefully, if we can get through them. But let's go ahead. Let me pull these up real quick. I'll close out the cholinergics. And we're not going to have as many adrenergic drugs. If I can find the slide set. There we go. And let me go to screen share here. Okay. So what we'll do is we're going to start with these. We'll take a little bit of a break. We're still on schedule. What we'll do is once we get through the adrenergic drugs, then basically you will have your, I've got a couple of videos, and you'll have your, we'll get to the adrenergics. We'll have your last 4 questions today, and then we'll let you go with a couple of videos that we've got here. But we'll take a break here and in about 10 minutes, maybe. We'll take a short break. So with the adrenergic drugs, we have, it's going to be very similar with regard to what we normally, like we did with the cholinergics. So we have a couple of, we have one other variation here. So we have a direct, these are the ones that will bind directly to the receptor. Okay, so just like with the cholinergics, the difference is the adrenergic drugs are going to bind either to an alpha-1, alpha-2, beta-1, or beta-2, or a combination of those. Whereas with the cholinergics, we were dealing with the muscarinic, nicotinic M, and nicotinic G. The indirect, in this particular case, most of the indirect agents, rather than interfering with an enzyme, most of these are going to induce the release of a transmitter. So with the acetylcholine or the cholinergic system, basically what we were dealing with is that those drugs interfere with the breakdown, whereas with the adrenergic drugs, most of these are going to deal with the issue of causing the release of the transmitter. And then we do have some mixed agents, which not only do they bind to the receptor, but they also may cause the release of the transmitter. So you have the drug binding and you have the transmitter binding. And just like with the cholinergics, we can actually predict what effect we should see based upon what receptors are being acted on. And when I've got this statement, the degree of penetration into the CNS. Some of these drugs will not go across the blood-brain barrier, such as the catecholamine derivatives. They can't cross the blood-brain barrier. Other drugs, ephedrine and some of those, can go across the blood-brain barrier. So as a review, remember that this comes back from when we talked about the autonomic nervous system many, many moons ago. So the alpha-1 responses, those typically, if it's got a 1 subscript, it's going to be excitatory. So alpha-1, stimulate the alpha-1 receptor, we get vasoconstriction. Stimulate the beta-1 receptor, we get increased force of contraction of the heart. Whereas the 2 subscripts are going to be more inhibitory. They vasodilate or they relax. Or, for example, with the alpha-2 receptors, they inhibit the release of transmitter. So we're going to start off with the catecholamines. And the catecholamines, basically, they're referred to this because their structure, they have this catechol ring, okay? So what we find is, of the catecholamines, what we find is we have norepinephrine, we have epinephrine, we have dopamine, and we have isoproterenol. So basically 4 of these drugs, okay? Typically, we're using these, for example, the norepi, epi, and dopamine. Those are going to be used short term. Isoproterenol, we typically use it short term, although a few years ago we were using isoprel for asthma. We used it sort of long term. We used it over several months, but typically it's going to be used more short term. So norepinephrine is a transmitter. You know what it is. It works pretty well. It's going to act on, notice it is going to act, let me get this there. So it's going to act on primarily, remember it has strong actions on alpha-1, alpha-2, and beta-1 receptors, but with norepinephrine, its actions on beta-2 receptors is very minimal. So it's not, for example, a good bronchodilator, which it's just primarily a beta-2 receptor. I had to take a moment there and close the door because of what you were hearing possibly in the background was Barney. And Barney was being a little upset. So one of the problems with using these catecholamines is predicting which receptors. So norepinephrine, what we see it used for is primarily as a vasoconstrictor, or we use it as a, we try to get it to raise blood pressure, or we can use it maybe sometimes to stimulate the heart rate. We use norepinephrine for treating sepsis, for example. We're actually doing some work looking on attitudes of using various vasoconstrictors. I'm working with one of our younger clinicians. So anyway, you don't want to use the norepinephrine for beta 2 receptors. Epinephrine acts on all receptors, alpha 1, alpha 2, beta 1, beta 2. So epinephrine can be used for stimulating the beta 2 receptor for for either vasodilation or bronchodilation in some instances. But we see its effects on blood vessels tend to be more of the alpha 1 receptor. Dopamine is very limited use. We use it as what is called a positive inotropic action. Use it to stimulate the heart. Basically, what it does is it's going to stimulate dopamine receptors. It doesn't get across the blood-brain barrier. So it's not going to, none of these will go across the blood-brain barrier. So none of them are going to have central actions, if you will. But we do see that really what we use dopamine for is by stimulating, it also stimulates the beta 1 receptor. So it's a heart stimulant. And the fact is that by stimulating the dopamine receptors, one of the things that we do see is that that helps to maintain renal function. So the dopamine receptors are involved in renal blood flow. At real high doses, you can actually get vasoconstriction because it can stimulate the alpha 1 receptor. And so that is a concern. And then with isoproterenol, that is primarily, notice it has no alpha 1 or alpha 2 actions. It's beta 1 and beta 2. So isoproterenol we're using primarily either as a cardiac stimulant because of the beta 1 receptor, or we are going to use it as a bronchodilator because of its beta 2 actions. So if you think about, let's go through each of these, and I've mentioned it a little bit, and I want to go through and say why it's used, what part of it is used. All right, so epinephrine occasionally can be used to produce mydriasis. Typically, we're going to use an anticholinergic drug to do that, but mydriasis is pupillary dilation, and sometimes epinephrine can be used, but a lot of times we're going to use a different drug. Primarily, its use is going to fall into one of these agents, one of these areas here. And so one of the things is localized vasoconstriction, okay? One of the things that they will do is basically used to when you would go to the dentist and they were going to fill a tooth, for example. One of the things that they do is they add epinephrine or can add epinephrine to the local anesthetic they're going to inject. So what happens with that is that the blood vessels, when they make the injection, the blood vessels vasoconstrict due to the epinephrine. So the advantage of that is it keeps the local anesthetic localized so it doesn't spread, and it also prolongs its action because it's got to diffuse away to be broken down. So we've seen epinephrine used for localized, to keep anesthesia localized. Some people you will hear, will say, well, I was getting a tooth filled and I started having all these palpitations. And we do know that there are individuals that sometimes the epinephrine, for example, it may have been injected close to a blood vessel or in a capillary type area. And what may happen is that the person may really have absorbed a little bit of the epinephrine systemically. So that localized vasoconstriction, the epinephrine may have gone away, but it's not going to get into the brain. So, but sometimes people have had a little bit of palpitations. Sometimes it's hard to tell because they may just be anxious over, what's going to be right time for the, it just depends on how it goes there. But there are other times when they're doing surgery that they may put epinephrine in, and the epinephrine it reduces bleeding, and it basically will maybe localize or keep the anesthetic in a localized place. I've seen it used for a bronchodilator, not frequently, but one time that you may see it used. The bronchodilation may occur, for example, when somebody is having an anaphylactic reaction. The histamine, remember we talked about the pharmacological antagonism and the physiological antagonism. So with the pharmacological antagonism, what's happening is basically when somebody goes into anaphylactic shock, we actually are going to use, that's the histamine being released. And so we're going to physiologically antagonize it by giving epinephrine, which is going to cause bronchodilation. So the histamine released because of the venom causes bronchoconstriction. And what we're going to do is we're going to use the epinephrine to cause bronchodilation. So that's the beta 2 action. We've used it as a cardiac stimulant. Somebody's heart's slowing down. We need to speed it up or get it contract a little bit harder. So what we've done is we basically will give isoproterenol to stimulate the beta 1 receptors. And then probably most people know about an EpiPen, and the EpiPens are used for anaphylactic reactions, which is what I talked about earlier. So the anaphylactic reactions, what you're seeing is you're getting an increase in blood pressure due to the alpha effects. You're getting an increased cardiac stimulation due to the beta 1 effects, and increased bronchodilation due to the beta 2 effects. So just to sort of summarize that, the localized vasoconstriction, that's due to interaction with alpha 1. The bronchodilation is beta 2. The cardiac stimulant actions are beta 1. And the anaphylactic reactions, we're looking at alpha 1, we're looking at beta 1, and beta 2 actions. Okay? Okay, let's do this. Let's take, let's go into the side effects in a minute, but let's take our last break. So let's come back at 5 after the hour. Actually, this is, we haven't had a long break. Let's come back at 10 after the hour, since I've got just a couple of minutes before. Come back at 10 after the hour, and we're going to finish up the these actions or these slides. So we've got about 13, 14 slides left. We'll finish these slides up, let you take your test, and we'll finish up there. So we'll have covered probably the adrenergics by this evening. So I'll see you guys at 10 after the hour. With norepinephrine and epi in particular. All right, so first of all, remember they're transmitters, and we're going to give them exogenously. So number one is that these drugs, can't cross the blood-brain barrier. What our biggest concern is their side effects are really extensions of the mechanism of action. So one of the things that can happen is we can get severe hypertension with these drugs. So for example, epinephrine comes in 2 different strengths. And if you pick up the wrong strength, I think one is 1 in 1,000, one is 1 in 100. And so if you picked up the stronger one and gave an injection thinking it was the 1 in 1,000, then we've had some pretty severe accidents. What'll happen is blood pressure goes sky high, and that can cause a stroke. Basically, what'll happen is blood pressure goes high and just blows out the arteries. Arrhythmias are not an uncommon thing that can occur when given it systemically. You're going to see that both of the drugs, norepinephrine and epi, are going to have the potential to stimulate the heart rate, make it go faster so people can go into a tachycardia. The less common, or I shouldn't say the less common, the less serious effects that we typically see is individuals will feel their heart beating, so they'll complain of palpitations. They may complain of headaches, which is due to vasodilation of some of the cerebral blood vessels. And the tremor is apparently is a beta action down in the skeletal muscle. So those have been reported. One of the concerns, you guys don't have to be worried about it because you're not going to be given epinephrine intravascularly, but sometimes when they would give it into the blood vessel, if they miss the blood vessel or poke through the blood vessel, that literally what can happen is where you are injecting, the site gets really blanched out and it can get ischemic because you get very severe vasoconstriction that occurs. In fact, that's one of the reasons why they prefer using epinephrine when they're given localized injections, because the epinephrine has beta 2 actions, and so you can get a little bit of vasodilation. What we really are concerned about with these drugs, again, probably the biggest thing that you would see with is somebody with an EpiPen, and that would be used to be, when they're having a reaction. But we do see somebody that's on a tricyclic antidepressant we can get some exaggerated responses. And the reason for that is, remember that tricyclic antidepressants are blocking the reuptake. And when we give these drugs, unlike the cholinergic drugs, the way that the body terminates the actions of norepi and epi is basically it takes some of it back up into the synapse. And also what it'll do is it uses monoamine oxidase and catecholomethyltransferase to break it down. So a person that's on a tricyclic antidepressant that gets epinephrine or norepinephrine, basically it will prevent or inhibit the reuptake and termination of its action, so it stays around a little bit longer. So those drugs we see, you know, epi, norepi, isoproterenol, and so forth, those we see used more in an emergency situation. So let's talk about a group which I've really categorized as miscellaneous adrenergic drugs. These drugs basically usually are subdivided really by their mechanism of action and clinical use. And so all of them have some sympathomimetic activity. Remember, we're going to talk about the blockers probably next time we meet, when we're going to be talking about cardiovascular drugs. And so we'll talk about like the alpha blockers and the beta blockers. So these other adrenergic drugs that we see used, we see them basically, they are vasoconstrictors. So we're using them primarily because of their alpha-1 activity. So let me just put this here, so the vasoconstrictors, well, the vasoconstrictors are primarily but by their alpha-1 activity. We see some that are used as CNS stimulants. Those have to cross the blood-brain barrier. So those are due to them getting across the blood-brain barrier. A lot of times those may be due to their alpha-2 actions. And then peripherally, we see the bronchodilators, and these we're primarily looking at their beta-2 actions. So from a peripheral standpoint, most of these adrenergic drugs, we're focusing on either their alpha-1 or their beta-2 actions. So let's start with one drug, ephedrine, which actually was used to be over the counter. We saw it sold quite a bit over the counter. Then it was pulled off the counter. We saw a lot of people abusing it. Excuse me. Had a beautiful day here in Georgia. The sun's been out. It's been in the 60s. So I've been looking outside, but I've had my door open, and unfortunately the pollen is pretty heavy. Has been coming in. A lot of stuff is blooming, but it's been gorgeous. But ephedrine, basically very similar to epinephrine and norepinephrine, but it's not a transmitter. It's a chemically synthesized drug, and it has some advantages. Epi or norepi we can't give orally. Epi and norepi both are very short acting. So ephedrine is orally effective, and we see that it can be given, does have a longer duration of action. So it's going to be very similar to epi and norepi. What we do see is this one does get across the central nervous system. So it, again, different from norepi or epi, ephedrine can get across the central nervous system, and it can be it can produce CNS stimulation. So that is, that's one of the big differences, and a lot of people used it for that. I mean, when you saw its use, what we would see a lot of times, we use it for its vasoconstrictive components. It is one of the very common drugs that we will use to either cause vasoconstriction to raise blood pressure. It also, that's its alpha-1 actions. It's a cardiac stimulant. It has beta-1 actions. It has beta-2 actions. And it's one of these mixed acting drugs, in the sense that not only does it stimulate the receptor itself, it'll bind to the receptor, so it's direct acting, but it will also cause the release of epinephrine or norepinephrine. one of the problems we run into that we can see is tachyphylaxis can develop because part of its actions is causing the release of norepi and epi. And remember, with tachyphylaxis, what happens is basically it will, you deplete the transmitter. So tachyphylaxis can occur. But typically vasoconstriction, which can raise blood pressure, and we do see it used as a pressor agent, which is used to elevate blood pressure. People that sometimes are undergoing surgery, especially spinal surgery, can go into hypotension. And so we will use it to raise blood pressure. It can produce tachycardia, so it can be used as a cardiac stimulant, but it's not really used that often for that. It will produce pupillary dilation or mydriasis, and that's just like epi and norepinephrine. The big difference here, orally effective, gets across the CNS, a longer duration of action. And the big thing with ephedrine was one of the reasons it was moved off counter was it was a it can produce a methamphetamine. So it became a very common precursor for meth, and that's one of the reasons that it went across the counter. Jason, I just saw your note there. Which slide were you talking about? Was that, let me go back and I can give you that. Was, okay, so you'll catch it on video, okay. And I apologize, it had just dropped below it. Below the little note here, and I just saw the two extra notes because it was pushed off screen. All right, so another drug that we use as a vasoconstrictor primarily is phenylephrine, okay? Phenylephrine is a direct-acting alpha agonist. It binds to the alpha receptor. And basically what we're seeing it used as is primarily an alpha-1 agonist. So where do we see this? A lot of times we use phenylephrine when people are having surgery, especially with spinal anesthesia. Blood pressure can drop, so we can use phenylephrine to raise their blood pressure. We can also see that it prolongs anesthesia. But probably where you see it the most is that pseudoephedrine, because it became a precursor that was commonly used for making methamphetamine. Pseudoephedrine basically it's in most states it is behind the counter. It's still available over the counter. But what happened is, for example, the common product over the counter called Sudafed, which is spelled S-U-D-A-P-H, I think S-U-D-A-F-E-D now. Sudafed basically has taken pseudoephedrine out of it and put in phenylephrine. So a lot of cough, cold, over-the-counter preparations, which used to have pseudoephedrine in it because people were abusing it and buying those drugs they had people they call Smurfs that would go into pharmacies and so forth and literally buy all of this they could and punch it out to extract the pseudoephedrine. So now you see most of the decongestants that used to have Sudafed in them now have phenylephrine. So when used topically, we see it in neosynephrine. When used topically, it is a nasal decongestant. So what a nasal decongestant does is basically when your nose gets stuffed up, the blood vessels are swollen and it clogs your breathing. And so what you do is you apply the phenylephrine, and what that will happen is that will cause those blood vessels to constrict. And basically when those constrict, that will then open up your nasal passages. We also see it used as a mydriatic to dilate the pupil. Again, other drugs are used, but phenylephrine has been used for that too. Methoxamine, I'm not requiring that you study this and know it, but it's another, it's a direct acting agonist. Basically, it is pure alpha, doesn't have any cardiac stimulation. But I give you this because it's an interesting thing of how we do it. Some people develop what is called paroxysmal atrial tachycardia, which means that their heart starts speeding up. Their atria of their heart beats faster. Now, one of the ways that you used to tell people to treat it is to tell them to rub their eyeballs. And when you rub your eyeballs, that stimulates the vagus nerve to fire. So what would happen is when your heart was speeding up and feel like people would rub their eyeballs, and the vagus nerve would release acetylcholine, which would slow the heart rate down. A few problems with that is that if you wear contact lenses, that becomes a little bit of a problem. But one of the things they use methoxamine for is to treat that. So people would take the methoxamine. So methoxamine would raise their blood pressure. And when it raised the blood pressure, what it would do is it would kick in the baroreceptor reflex, which would cause the paroxysmal supraventricular or atrial arrhythmias to be suppressed. So it was an indirect way of using it, and I always include that just as sort of an interesting use of these drugs. Now, mentioned this earlier, but we have a whole bunch of drugs that are out there that are used as nasal decongestants. And basically, if you go to any drugstore, any place where they sell cough cold preparations, again, we see things like pseudoephedrine, phenylephrine. Those are two of the big ones. And these nasal decongestants are primarily acting on alpha-1 receptors. And what they're doing is they're causing the blood vessels in the nose to constrict, which opens up your nasal passage. People get addicted to these in a sense. What'll happen is they will use them constantly every time.
Sorry, I can't search the web on Apple Watch.
For some reason, my Apple Watch on Siri decided that they're not going to do it. Not going to search the web. I don't know what I asked her to search the web for. But what'll happen is people will get used to these. And for example, we see smokers and things like that. And they will just constantly use it. We'll see people buy this stuff by the case sometimes. And what can happen is that with constant use, you get almost a rebound congestion. It'll develop a chronic rhinitis, which is basically an inflammation of the nasal passage. And so that when you get that inflammatory component there, you actually get congestion that's worse than what you were trying to treat. So we do see people that tend to overabuse this. Every time they get a stuffy nose, and this can occur especially with a lot of allergies and stuff like that, they're just constantly snorting this. And what actually, it makes the situation worse. Also, they can develop by constantly stimulating the receptors, you get a downregulation of receptors, which means the drug doesn't work as well. Systemic effects, typically, if you're using it as suggested, you're not going to get these systemic effects. But in some individuals, if they get enough systemic, for example, their blood pressure can go up, so it can cause hypertension. We may see some palpitations that occur, some dizziness, so that can occur. Many times these are combined with antihistamines, so people use an antihistamine combined. A lot of cough cold preparations will have an antihistamine and this. Take something like NyQuil. NyQuil will have usually phenylephrine and something like diphenhydramine or chlorpheniramine. Guaifenesin can have will have an antihistamine in it. So a lot of times either you're hitting the decongestion in two different ways. You're using the antihistamine to block the effects of histamine, which is causing it, or apparently causing it, and then we're using the alpha adrenergic to block that, or not to block, to stimulate the alpha adrenergic component to cause vasoconstriction. A couple of the ones we see, we've got some of these that they all act the same way. Some are longer acting, things like oxymetazoline, xylometazoline. They tend to be a little longer acting. Most of the agents now we see are typically phenylephrine, pseudoephedrine. Personally, I like pseudoephedrine. I think it works a little better than phenylephrine, but pseudoephedrine you have to sign for. So it's a little bit more what it happens to do. Arnold, you asked about the saline spray. It's sort of like the neti pot. The idea here is the saline spray, it moistens the mucous membranes and it also washes them out. So the idea is things that are allergens that get in your nose, they then stimulate release of histamine. So the saline spray basically is partly washing out those allergens, which should reduce the amount of histamine that's going to be released. Same process. The neti pot does the same thing. It's flushing the area. We do see that in some children, a drug called nefazoline, which was a nasal decongestant, can sometimes produce profound drowsiness in children, and there has been some reports of a coma. we see if when it was really abused, that was it. What we see more commonly used is not nifazoline, but we see tetrahydrolazine. Many of these drugs are not used so much as nasal decongestants. They are now used more for redness of the eyes. These, Visine is basically, I think Visine is tetrahydrolazine. What the idea is, your eyes turn red because the blood vessels in the eyes dilate. So when the blood vessels dilate, your eyes look really red. So when you use these drugs, literally what you're doing is you are vasoconstricting those blood vessels. So the reason it clears your eyes is it's taking those dilated blood vessels and vasoconstricting them. So any of these agents that you see for, a lot of things like a lot of allergies and stuff, well, the histamine will cause your eyes to get red and itchy. And the idea is by reducing the red, gets the red out, you're just basically causing vasoconstriction. Another group of these drugs, and we'll talk about these a little bit more when we talk about pulmonary drugs, but bronchodilators. Isoproterenol, we mentioned earlier today, it's primarily beta-1 and beta-2. A couple of things with isoproterenol is, one, if you're trying to get a bronchodilator, you want the beta-2 action. Let me just go ahead and put that up here. So what you're really hoping for is beta-2. And you really don't want beta-1 because beta-1 causes your heart rate to speed up, heart to speed harder. So people that are using isoproterenol, when they were using it, sometimes their heart would start racing. So if we can use a beta-2 receptor or beta-2 specific drug, that avoids the beta-1 actions. And the other thing about isoproterenol was actually it's broken down into a metabolite that is that's actually a beta blocker. So when you start using it, two things happen. With chronic use is, one, you build up this metabolite, which diminishes its effect. And secondly, again, think about downregulation of receptors, that when you keep stimulating this receptor, they downregulate. The non-selective action of isoproterenol is usually the beta-1 component, or if you're using another drug that has beta-2, for example, if you're using something like epinephrine or norepinephrine, those really don't work really well because they don't have a long-acting. What we've done is we've actually developed some agents that are more specific. And the two agents that we see used a lot is albuterol, which is very commonly used for asthmatics. It's almost pure beta-2. There's also a metaproterenol, which is beta-2. So we've done two things to reduce side effects and have a greater effect. More selective agents, so more selective beta-2. And again, by using an inhaler, we're giving a localized, we're putting it straight onto the bronchioles, and we're not, if you take it, systemically, and even if it's a beta-2 effect, you could have effects on beta-2 receptors, such as one concern would be it could drop blood pressure. Another concern, if a woman was pregnant, beta-2 stimulation could possibly affect the uterus and cause premature pregnancy, a premature delivery. So that is sort of an overview of the adrenergic agents. We're using them more as cardiac stimulants. We're using them more as bronchodilators, and also as to vasoconstrict, either raise blood pressure or to reduce the redness by causing vasoconstriction. So their actions are pretty close with regard to that. We will talk about bronchodilators in more detail when we talk about anti-asthmatic drugs and pulmonary drugs. We will talk a little bit more about some of these other agents, and definitely about the alpha and beta blockers will be covered next week we meet. Tomorrow, we're going to pick up on antihistamines. We'll start with that, and I was just checking to see. So Aiden, if you want to get ready to put up the final 4 questions, and if you guys will remind me for in the morning, when we start, I will go over the answers to the 4 questions. So the afternoon questions are primarily dealing with all adrenergic drugs. So answer these questions, and I've sent Aiden, I think, Aiden, you should have received there's 3 short videos dealing with adrenergic and neuromuscular blocking drugs for you guys to look at. So if you guys will look at those videos, finish the quiz, and then again, remind me in the morning, and I'll go over the answers to these 4 questions here. So does anybody have any question? All right.
Doctor,
Well,
already the videos are uploaded.
Again, Aiden, I think you should have the video. And if you'll just make sure to save the recording on this one, and we'll be good to go. And I think Marissa's taking over in the morning. And Aiden, you have a great week. And I'll see you guys later.
Thank you, Doctor.
So I'm going to go ahead and sign off.
All right. I'm going to keep the poll running for another 10 minutes, and then I'm going to close the session.